Good morning, everyone, and welcome to today's Landlord Outreach Supportive Housing Training, Understanding the Social Determinants of Health in the Context of Supportive Housing Services. My name is Dawn Reinhardt Wood from Rutgers University School of Health Professions, Department of Psychiatric Rehabilitation and Counseling Professions. That's always a mouthful. And I am joined today by my partner, Emily Bands, and we're going to take you through this training. So let's get started. So today we're going to cover, first, I should say, I realized that we didn't have our little housekeeping slides in here. I just wanted to say that today's presentation is presented in partnership and with sponsorship by Washington State DBHR and is targeted to, FCS programs. So today we're going to go through three main learning objectives that we hope you'll take away by the end of this training. Those are to describe the social determinants of health, to identify factors that contribute to unequal access to resources for supportive housing recipients, and to recognize the impacts of things like food and medical deserts on supportive housing service recipients, and obviously others. Anyone experiencing a food desert, medical desert, are going to face unmet needs and challenges. So let's take a moment to kind of define what social determinants are when we talk about them. What do we mean by that? So these are the things outside of, when we think sometimes about health, whether it be primary medical or physical health, or its connection with our psychiatric health, our mental health, very often we're thinking about those biological predictors, right? And perhaps environmental stressors. So we are specifically talking about things that are found in the environment that can predict and contribute, sometimes negatively, to the long-term health outcomes for individuals that we're serving and working with, and really for all of us. So some of the environmental conditions that we're looking at are things like, the environment that the individual lives in. Let's go back to their birth, the environment that the individual is born into, their primary caretaking social group. What does that look like? Does that family have the resources, or does that parent have the resources that are needed to adequately address a growing child and all of those developmental and physical needs and emotional needs that a little human being has? And then the environment that the individual lives in, again, and we're not just talking about the individual's primary social group, but what is that environment like outside that family unit? What does the community look like? Is there a lot of crime in the community? Is it an impoverished community? Is it rural and disconnected from other services, right? So when we think about this and the environments that people live in, it's important to remember that we're not just talking about inner city areas or extremely remote areas. These kinds of challenges can pop up in a multitude of areas. Obviously I live in New Jersey. I live in a fairly populated county. It's the largest by geographic area in New Jersey. And yet our public transportation system is horrific. We don't have the infrastructure that population centers around the Philadelphia area of New Jersey and the metro New York City area have, right? So that also limits accesses. So when you're thinking about some of these social determinants, think about those other things like our infrastructure. I recently heard an individual on one of the cable news networks, and I don't remember which one it was. I can tell you which one it probably wasn't, but I won't go there. But one of the cable news networks that was talking about the way that our infrastructure even sets up barriers, maybe not, I would hope that it's not purposefully, but that our infrastructure has some systemic issues in it that negatively can affect individuals of lower incomes and certain races, et cetera. So these are also, we need to be thinking about some of like these global things in the environment that could support or not support our development. The environments in which people learn, right? Do folks have access to adequate education? Are those educational settings set up to support individuals who may have additional needs, right? In areas, I am lucky to live in a town, and it's funny to say it this way, but prior to the push for early childhood education and starting before the age of 4 years old, so that push for pre-K education, in New Jersey, only certain districts received pre-K education for 3 to 4 year olds. And those were the districts that were deemed to be the most impoverished. I happen to have been born, raised, and continue to live in a city that has that designation. And so my son was able to access pre-K services. This is becoming more common nationwide, but consider the child who doesn't have access to those early services that can really even, what I like almost most about it, beyond some of the social and educational aspects of that experience, is the ability to pick up on things early, right? To have an educator, to have educated eyes outside of the parent to pick up on things that may seem abnormal or indicators of conditions that we can assess for, address, and hopefully set the child on a track for a more positive learning experience. Work, access to work opportunities that are supportive of individuals. When we think about the individuals that we're serving and working with, are these work opportunities inclusive and accepting and supportive of individuals who may have certain disabilities or conditions in which they may need additional supports or accommodations. Play. So, very often we talk about being happy, and the goal of most human beings is to live, love, work, and play. I think Freud coined live, love, and work. And then I think we've kind of expanded on that a little bit more. So that opportunity for safe play, for exploratory play, so much happens for children when they're able to interact. From the time I know that, like, as a mom, and my child is nearing 15 now, I look back to when he was a 2 or 3 year old and engaged in that like parallel play where they're present with each other. They're kind of it's kind of like they're interacting, but not quite. But it really allows for them to start to develop socially, to understand their boundaries, to handle conflict, right, on the playground, but hopefully in a safe way. Children are going to have disagreements. Children are going to get into little spars and fights and these sorts of things, but are they in an environment that is supervised, that is not just, out in a playground in an environment that's dangerous, or we, perhaps the parent or the caretaker who can't even consider letting their child out to play because the neighborhood is just so dangerous. And opportunities to worship. So there are, there's a lot of research that suggests that spirituality and positive experiences, I'm going to put that qualifier on it, that positive experiences with religion and spirituality can support our recovery from a multitude of conditions, right? If we're able to gain a positive outlook and a feeling of not being so alone and being united in some sort of idea or belief system, this can be very, very beneficial to individuals. We also know that there are situations in almost any institution, whether we're looking at a religious institution, an academic institution, a healthcare institution, where there may be experiences that aren't so positive, right? Where a child may not have a lot of choice. They may have some of their autonomy taken away. And so we need to also acknowledge that people may have negative interactions or experiences in kind of this area of, or this domain of religion and spirituality. But we want to make sure that people have that access, that choice to participate or to not participate. And you will see that a lot of these, well, all of these environmental conditions, maybe except the born part, these are all aspects that supportive housing service providers are addressing, right? We may not call it play when we talk to our adult service recipients, but we all play. We all have our version of play, right? That may look like, for me, playing goofy games on my phone until 2:00 in the morning, but that's my play, right? So, or gardening or whatever. So those leisurely activities and those opportunities to have fun, to enjoy, and to do things other than work and other responsibilities. So these environmental conditions do have an impact on the outcomes of our physical and mental health, our overall quality of life, how we rate our quality of life. And there are, there have been studies and there are validated scales. The QOL is a very popular one, the quality of life scale, which measures multiple dimensions of an individual's life and how they self-rate their quality of life. And so by bolstering and firming up some of these, all of these environmental conditions, we are shooting for more positive outcomes in health, quality of life, and overall well-being, including a person's emotional well-being, their physical well-being, their spiritual well-being, and so on. So, what are the things that influence these social determinants, and how, what our experience is going to be like? I may have touched on some of these when I was blathering on the last slide, getting caught up in my own kind of dialogue. But so we see that there are these three factors that tend to most impactfully affect social determinants. And those are racism, which I don't think I need to explain racism or discrimination or violence to any of you. And just considering, when I was talking about things like a family having a safe place for their 9-year-old child to play, right? Imagine not being able to send that child to the playground because of this fear that other members in the community or outside of the community that may come in could potentially harm them. So, and these are some issues that folks who are privileged enough to not, encounter these environmental conditions, it may almost be invisible to them, and they may not consider that. And this is one of the reasons why we want to talk about that, because not everybody has the same experience growing up, right? Like, I was able to go outside and play. Also, I'm a Gen Xer, so my parents kicked me out at like 9 a.m. on the weekend. And I pretty much wasn't allowed to come back in until lunchtime, and then again at dinner time. I was thrown back out there again, and not in a mean way, but it was just, it's nice out, go outside, you're going to play. And they didn't hear from me for hours and hours and hours at a time, right? And it was safe to do that. I cringe at that thought now with my son. Well, he's 15 now, he can kind of take care of himself. But when he was 6, 7, 8 years old, I didn't feel comfortable doing that. And so that's because our environment changed a little bit. I lived in the same house. I raised my son in the same house that I grew up in, but the environment changed. So some of the things within these three, we kind of chunked it out into vocational, educational, environmental, and health. The way that the racism, violence, and discrimination can affect these three categories are by things like income, right? Individuals being paid lesser rates because of their race or because of their gender, because of, perhaps their English proficiency and things like this. Educational level, employment, overall literacy. So, and we're not just talking about English proficiency. There are other areas of literacy that tend to be, kind of underemphasized. Things like financial literacy. Do kids' parents or their caretakers have conversations with them? Are they prepared by their school systems to know even how to pay bills? A colleague of mine and I were talking recently about the disappearance of home economics classes in high schools. And that's how I learned how to write checks when I was in high school. My mom didn't teach me that. I just wasn't something that came up to her, but that's how I learned how to make a budget and pay bills. And I understood how to do that by the time I was 17 and graduated. And so like, do people have access to these services? And language skills. And again, not just the basics of, do you know English, or if you're living in a bilingual area, are you able to communicate at least at a basic level with other individuals, but also the nuances of language, some of the other nonverbals and some of the other kind of customs that come into play. Environmental, so housing, do individuals have access to safe, decent, affordable housing? Oftentimes people may have access to affordable housing, but they're not in areas that we would consider safe and decent, right, for an individual, or conducive. I will say, when I say decent, I mean conducive to a person's overall wellness. Transportation, we discussed how that could be an issue in some areas of our country, some areas of our, within our states, we can see a lot of variation in access to transportation services. Safety of neighborhoods, air or water pollution. It's making me think about the train derailment in Ohio, and then there was a subsequent train derailment by the same company. When people are living in areas where there are these true, like, I don't want to say true, but there are these natural environmental risks also, whether they be like fire, flooding, pollution. We should also consider those. And I have to move, let me see, my closed captioning is blocking the last box. And health. So do folks have access to adequate health care? Do they have access to that? Do they have to wait a long time for an appointment because they're reliant on like a public health clinic or a federally qualified healthcare center? Do they have access to a doctor, but that doctor is so overburdened because they might be in a rural area or even maybe in an urban area, and their caseloads are so high, and so they can't take the time needed? Access to nutritious foods. I don't want to get too deep into this because I know Emily is going to cover it, but this idea of food deserts, doesn't just mean that there is no food. It also might mean that the food is much more expensive because you're buying from a convenience store or a local mom and pop. The selection might not be there. The nutrition might not be there, right? The availability of things like fruits and vegetables and grains. And physical activity. So again, thinking about how, like, if I'm living in an unsafe neighborhood and I work 9 to 5-ish, and the only time I have really left to exercise is maybe after the sun goes down, am I going to go out and run? Well, I'm never going to run, so don't worry about that. But am I going to be able to go out and walk and exercise and do what I need to do in order to maintain my physical health? And that could be more and more. We could see increasing like sedentary lifestyles when individuals can't do that. And so when we think about like the development of health conditions that a lot of us as Americans and a lot of individuals with mental health conditions may have, and we think about the medications they may be on, we know that physical activity and diet is something that's really important to keep an eye on in their lives, right? And yet if they're on a, say, atypical antipsychotic medication or an antidepressant that may contribute to weight gain or metabolic syndrome or cause prediabetes or aggravate an individual's diabetes that they may be living with, they don't have that access to the nutritional food supply, to healthcare that's going to look at them from a holistic point of view and consider their dietary needs in the face of some of their other health conditions, and have access to that physical health or physical activity we may see those conditions, those secondary, I don't want to say secondary, but those medical conditions that are co-occurring with a mental health condition get worse and have a poorer prognosis and ultimately lead to a shorter lifespan. Okay. Excuse me. And so let's talk about, what happens when services shut down. Consider what happened during, I always say during COVID. We're still experiencing COVID. I had a conversation earlier today and we said, yeah, it's been 3 years. It'll be 3 years next week that we were told to go home. It'll probably be a week or two, and then you can come back to campus or come back to the hospital you were working at. It's 3 years later. I've been working from home, right? But think about what it looked like in that first month, 6 months even, when things were locked down solid. So individuals who already were experiencing kind of this deficit of environmental supports even faced a wider gap in terms of accessing the resources that they needed. So things like, food stores closing during the pandemic, hospitals limiting services to things that were emergent or urgent, no elective kind of preventative types of interventions. And then even outside of a pandemic or a natural disaster type situation, we could think about, businesses simply moving out of towns, right? In areas where we may have a lower socioeconomic kind of environment. Businesses may just feel as if they're not making the profit that they can and leave those kind of urban centers or even, some rural like meeting centers. And this directly impacts an individual's access to healthy and affordable foods, and then complicated by perhaps inability to use public transportation because of financial issues or just simply lack of access. So these environmental issues can compound one on top of another, right? So sometimes we think about, when we think about things like the concept of intersectionality and how individuals' personal characteristics and biological characteristics and affinity group characteristics can kind of, compound the stigma that they experience and some of the negative experiences. We can also see the same thing happen with these social determinants as well. Next slide, please. Oh, I'm doing the slides and I'm asking Emily. That was funny. I've never done that before. Next slide, please, Dawn. So let's talk a little about food insecurity. So these are the prevalence rates here in the United States. The national average for individuals with food insecurity is over 10%. So when we think about food insecurity, it's this idea that, and some of you who have filled out national surveys, I don't know, I'm not sure if they asked it on the census, but I know that there's been things like, might have been my taxes or some kind of government document that I completed. Oh, no, I remember it was for a doctor's visit. For doctor's visits now, I noticed my healthcare provider is asking about food insecurity. They're asking if you're having to skip meals, if there's times when you fed your children, but not yourself. So this is where a lot of this data is coming from. It's probably also coming from some of the more nationalized studies from SAMHSA and other institutes of health. But doctors are becoming more aware of this because it can directly contribute to the health outcomes of their patients that they serve. So we're asking about this more. But you see, when you look at the national average and then you go on to the next 2 points, in Black households, the experience is almost 22%. So near a quarter of the population have experienced food insecurity. And they typically ask in the last year. And Hispanic households, 17%, so slightly lower, but still an alarming number. So you're thinking about 1 in 5 Black or Hispanic households are maybe experiencing food insufficiency. And adults with disabilities have a greater risk of food insecurity. So again, it says here due to lack of employment opportunities. So people with psychiatric conditions are notoriously underemployed, but for a multitude of reasons, but notoriously underemployed and have a lower net income annually. They also may incur increased expenses, such as towards healthcare, prescription copays, and so on. And again, this is when we're thinking about, this set of environmental or social determinants, and then we're layering this other condition upon it, right? So that individuals bringing with them all of the challenges and barriers that may come along with or be associated with having a diagnosis of a psychiatric condition. Okay. So what are some of the causes of food insecurity? It tends to be based on area. So when we have both urban, rural, and low income, or I shouldn't say both, but either urban, rural, or low income area. And remember, places could be urban and low income, rural and low income, or just urban or just rural. Very often there is a lack of transportation or a lack of, I want to say saturation also, which goes hand in hand, right? So a lack of saturation of viable, affordable, healthy places to access food. Instead of a 7-Eleven here in New Jersey, we also have other convenience stores, Wawa and Quick Check. If you ever visit, you have to visit them. Wawa's the best though. But those aren't really places that I think of when I think of healthy food options, although my lunch came from Wawa today. But, this access to adequate food resources. So if they lack access to a food store, where are they going to get their food from? I just mentioned a couple places like convenience stores. We also have a lot of corner stores or bodegas in some of our more urban areas. But again, they're not usually offering a wide variety of produce. They're not usually offering a wide variety of lean meats, right? They're not offering vegetarian options if an individual is living that lifestyle or making that health choice. And so again, it is limiting the individual's options. Can anybody think of any other places where people obtain food from when they don't have access to what we would think of as a fully operational grocery store? I know that some individuals that I've worked with engaged in a lot of food trading, food stamp trading, trading of other resources for food. Food became a commodity with individuals that I worked with, cigarettes as well, but food was very often a commodity, right? So an individual would get something from a food pantry or a food bank, and they would use it as a commodity because they couldn't access the ingredients that they needed for cooking and for other ways. So there was like this little economy going on with some of the individuals that I worked with. Oh, okay, let me just. So we have a short video that we'd like to play, getting food in a food desert. So let's take a look at this and see what people experience when they're attempting to just simply nourish themselves. Okay, Emily, when I start this, can you just let me know if you hear it okay? And all right.
Got the bag. This is Toni Lawson. She lives in the southeast part of Washington, D.C., a predominantly poor neighborhood.
Got the bag.
Your bag?
Yeah, the
You
shopping
want to
bag.
go grab it?
Yeah, because I don't have any money to buy bags.
If, like Toni, you live in a lower income community, have no access to a vehicle, and live more than a half a mile away from the grocery store, you live in a food desert.
Try not to miss the bus.
Tony retired from a career in the insurance industry 10 years ago and receives food stamps on the 6th of every month.
I don't think this was an accident, not to build grocery stores in this area because the people here, it's not just about Black people, it's about poor people.
Route A4. Destination.
Tony is one of more than 23.5 million Americans who live in a neighborhood which the USDA calls a food desert. That means they have limited access to healthy, fresh, and affordable food. For Tony, getting groceries requires traveling 2 miles with the help of 2 buses. It takes 40 minutes each way. It's a struggle to get there, especially when you're 71 and have to carry a week's worth of groceries back home without a car. In Washington, more than 80% of food deserts are located in the neighborhoods with the highest poverty rates and where mostly Black residents live. In whiter and wealthier parts of town, there are plenty of big box grocery stores and independently owned supermarkets. But in Southeast DC, leading chains don't feel like there's enough money to be made in those poorer neighborhoods. The higher rate of crime in Southeast is another deterrent. So if you want to buy food in Southeast DC, you generally have to get fast food or go to a convenience store. That leaves 150,000 people in the area in a food desert.
Now we're calling it what it is, food apartheid. It's something that's planned. The desert is natural. It's manufactured by the planet. This is something that's planned. And it's obvious.
Tony buys her food from multiple grocery stores, searching for the best deals. Here she is at Giant, her closest grocery store, trying to find some staples on sale.
There are not a lot of places in the area where I live that I can go and buy food. What I do is I get my bulk when I get my stamps. I run all over the city. Even though the Giant is here, I don't patronize the Giant very often because it's expensive. So I'm running all over the city.
Tony is tired of traveling across the city hunting for food. She wants more healthy food options for everyone in the neighborhood. So she's training to be a community advocate, pressing the DC government to provide incentives that will attract more grocery stores to come here. Her goal is simple.
I've been in Ward 8 21 years, and we have not had a full service supermarket for that entire time. There's always been a break. In my area, I want to see more places for people to shop.
For NPR, I'm Sasha Ann Simons in Washington.
Okay, so maybe we should go to the chat. I'm wondering what people thought about that and if you've seen similar experiences with some of the people that you work with. No? Okay. Okay. So I love this slide. Food deserts are food swamps. Okay. So what happens when individuals are faced with or being confronted with living in a food desert? So let's look at this phenomena of, or I shouldn't say phenomena because it looks very planful. It's not really a phenomena, but this experience of living in an area where there is a supermarket void or a grocery store void. Very often what this contributes to is over-reliance on convenience food stores, which is associated with, not or having a limited offering of food choices and especially healthy, nutritious choices, or at least a balance of healthy and not so healthy. Increased access and reliance on processed foods. So, not only the things that might be bought in a food bank, but also those things that might be like more shelf stable and they may acquire from food pantries and food banks. And that's not to ding food pantries or food banks, But that sometimes, there is this over reliance on things that are ultra processed or processed. This stuff has to last longer, right? So you may not be buying the freshest of the food options or the item that you desire. You may be buying it in an adulterated form because it needs to last, or you're purchasing it from a store like a convenience store or something that doesn't have the same breadth of offerings. And also little or high cost fresh food. So when, foods are a premium, when you're purchasing produce at a convenience store, you're going to pay $1 for that piece of fruit when you could have potentially paid $2.99 for a pound of that fruit, right? So we're in a grocery store. So we see that cost inflation also occur. And so for individuals who are already on a fixed or limited income, this exacerbates their financial problems and also may cause them to choose to eat less. People in food deserts.
I think it should say they eat more food.
What's that? Eat more processed food. Yeah. So just a slight correction on that first little bubble or square under people in food deserts. It should say they eat more processed food, which we know is associated with poor health outcomes, right? Increased cholesterol, diabetes, all those other unfun things that tend to be lifestyle and age related. There is a genetic component to it as well, but a lot of those conditions like hypertension and other metabolic conditions like diabetes and cholesterol issues could obviously be exacerbated by our lifestyle and diets. They tend to spend more money. So again, these are folks that we're working with that don't have all that extra money to spend, and they're spending more money on their food budgets per person because food is at a premium when they finally do access it. They may be paying additional expenses for transportation, paying people for rides, things like that to get to those locations where they can actually secure food. And they are more likely to have physical health conditions like diabetes, hypertension, heart disease, and associated conditions like I just discussed, which makes our jobs a lot harder, right? So we're not just focused on an individual's experience of homelessness and trying to remediate that and prevent that from occurring again, and also focusing on their emotional health and helping to get their mental health services in place, and get them and work with them to see them recover. But we also have to consider all these other co-occurring health conditions. And how can you tell a good supermarket from a bad supermarket? What does a good supermarket look like, you all? Where's a supermarket or what would be the characteristics of a good supermarket? Yeah, that's important too, Christina, right? So not only is there a variety of options, but they actually care about the employees and maybe even they care about their customers, right? So like they're welcoming, they want you to come back, they're not hovering over you when you're shopping. Yeah, so we're talking about cleanliness. A green leaf, I don't know what a green leaf is. Is that a grocery store? Sounds like it. Low cost, wide variety of food options, clean, well-stocked. Yeah, absolutely. So all of these things are things that when you consider where individuals with food deserts are forced to shop, they're not really seeing this in their options. When we saw that video of Tony, she said, Giant's a nice store, but it's way too expensive. I actually have that experience with Giant in New Jersey as well. It's way too expensive, so I don't shop there. But I actually have that choice, right? Like I have a car, I can get there. I do not live within a half mile of a grocery store, and I do live in an urban environment. And my friends and I have talked about our town being a food desert because there are no food stores other than convenience stores and bodegas in my town. But I have the options to connect with those resources, right? So great. So thank you for offering those observations in the chat, because these are the things that our service recipients may not be seeing when they are accessing their local food resources. And I think we kind of covered that, good versus a bad supermarket. So we want to find out from you in the chat, if you could, let us know, what are some of the common challenges the folks that you serve face when accessing healthy and affordable food that you see in your location? Like I said, in my area, the biggest thing is probably transportation. Yeah. So no transportation or limitations due to the bus routes and work schedules, right? Transportation might not be available when when it's convenient for the individual. So you're at the whim of public transportation. If you've ever been at the whim of public transportation, it's not a great feeling. High inflation. So we can't ignore that. Food prices are rising for everybody. Several weeks ago, I paid $5 for a dozen eggs. I haven't touched one of those darn eggs yet because I'm like, they are priceless at this point. I have to make something really good with those $5 eggs. Sugar tax. Yes. Thank you, Deonte. And if I said your name wrong, I apologize and please correct me. We have some local, cities, Philadelphia is one of them. Philadelphia is about 15 minutes from me, and there is a sugar soda tax, right? So if you were to buy even high C, a fruit punch, you would get hit with a pretty hefty sugar tax within the Philadelphia city limits. And I'm not saying that, fruit punch is a great option. I love it, but great option for your child, or that soda is a great option. But again, it's about having that option, right? And so people are being overtaxed in areas where the socioeconomic status is already lower, and they don't have the options that maybe other folks have within the city to drive out of the city and buy their Coca-Cola. So Sarah said people on SNAP, which is the food benefit program, the federal food benefit program, can't buy pre-prepared foods despite potentially not having access to a kitchen to cook healthy meals. Yes. So I will say I do have a tip for that, and I don't know if this will be helpful for anybody. When I worked directly in supportive housing with service recipients, I was able to discover that through Medicaid, if an individual has certain healthcare conditions or health conditions like diabetes, maybe kidney disease, there are certain qualifying conditions that they might have to have. And if they're on SSI, which is supplemental security income, and received Medicaid, in some cases, they're able to get food delivered, that pre-prepared food that only needs to be warmed up. It's something called Mom's Meals. I'm going to put a little plug out there for them. And I'm sure there's a variety of companies that do this, but they would actually deliver the individual's meals, which was so helpful for us because we had individuals who maybe didn't have the cooking skills or who had physical impediments that they could not stand and cook for themselves for prolonged periods of time. Yeah, I'll just type it in here. Again, it's not an advertisement. I don't know how great their food is. I don't know how great the organization is to work with because it's been so long. It's been almost 20 years. But that is a resource for individuals, and Medicaid actually paid for the food because it was a medically prescribed diet by the doctor. So in navigating the world of food deserts, we also have to be, we're also challenged to think creatively, right? So these are the conversations that I would suggest that you also have with your service recipients, healthcare providers as well. If you know that they don't have access to the foods that the nutritionist or the doctor is advising them to eat, have them bring it up. Chicken Soup Brigade, I love that. Yeah, Meals on Wheels are great too. I love this. I love that you guys are sharing all these resources. This is great. So we kind of started to get into this, and I apologize for that. I jumped the gun, but are there any other ideas that you may have? So I talked about Mom's Meals. A couple of you also talked about Meals on Wheels, Chicken Soup Brigade. Are there other ways that people can access or support access to healthy and affordable food? And what can we do as providers to help them with that? Yes, Amazon does take SNAP. Food banks, absolutely. We have a fabulous one, South Jersey Food Bank in New Jersey. And they support a lot of the local pantries, and they can be phenomenal resources. Food bank delivery would be great. So there's some, I know in New Jersey, some of the churches that participate in food pantries, some of them get a little bit of money for outreach, and so they're able to deliver to folks, but they have to meet certain like they have to have, you know, physical limitations, these sorts of things. And that doesn't really address the issue I think that a lot of us are talking about, which is really just this, you know, living in areas where they don't have access to transportation to get to food pantries and the like. But yeah, and we're seeing increasing vendors or stores accepting things like EBT or SNAP benefits, right? So Amazon absolutely takes it. A lot of, I think somebody said a farmer's market. So we have several farmers markets around me because I live in a interesting area, urban, and then 1 mile away, it's rural, that also take food stamp benefits. So, you know, transportation vouchers, absolutely. So asking for those things, asking for transportation vouchers, helping an individual get qualified for a, you know, in New Jersey, we just kind of globally call it like a free bus pass kind of thing. So like helping them get access to those benefits that they are entitled to because of either a certified disability status or some of the other benefits or their income restrictions that they have. Yeah, community gardens are great. So my most, one of my treasured memories of working in supportive housing, at one point when I was the director of supportive housing and our homeless outreach programs, we partnered with our county because of this issue of our service recipients not having access to healthy foods. The county had a community garden cooperative, and like an agricultural cooperative, and it cost something like $50 a year or a season to have a plot and to farm that plot. Because we were a nonprofit organization, they waived our fee. We asked a little more, and actually Rutgers University, I wasn't working for Rutgers at the time, their agricultural cooperative gave us seeds, gave us plants, gave us compost, even came out and were willing to give my clients like a little, or my service recipients, a little class on how to start a vegetable garden. And so it achieved a couple things, right? So folks who plowed it and tended to the garden, they were able to have access to the fruits of their labors. And it also gave them so much confidence and agency and self-motivation to be able to see something from dirt to seed to an edible fruit or produce. It was a wonderful experience for them and for me. Okay, let's see. Any other ways? Thank you for that note, Monica. It is important to understand how accessing one benefit can impact the other, right? So I appreciate that.
I think I'm up, Dawn.
Okay, let me.
So I just want to say that was like a really good conversation on food deserts. And it sounds, I'm happy that the information that was discussed, it seemed helpful to everybody. And it seems like what you all are experiencing out in Washington State is very similar to what the individuals we work with in New Jersey are also experiencing. So I'm hoping that when we switch gears a little bit and now look at this idea of medical deserts, that this might also be information relevant to you guys. So we talked about this reduced access to food and food stores. So now we're going to switch gears and talk a little bit about reduced access to healthcare. And when we're talking about this, it's very important to consider how these barriers to healthcare are going to directly impact these poor outcomes for the individuals that you're working with. So the three main barriers to healthcare are going to be health insurance, shortage of providers, and then the lack of transportation, right? Transportation seems to be a very big and challenging issue for a lot of the topics that kind of fall under these social determinants of health. But for health insurance, right, we're thinking about that lack of or partial coverage. And how this is impactful is it's going to potentially delay care, right? Because if somebody doesn't have coverage or only has partial coverage, they're not going to be as motivated to go and get the issue taken care of because they know it's going to cause a bill and they know that they can't potentially pay for it. And then that's what leads to this incurring of out-of-pocket expenses. Does this happen for any of you out there who have individuals with Medicare? Because this was a big challenge that I faced when I worked in the community with individuals who were only on Medicare. They did not have Medicaid. It was very challenging them to get medical care at times, and they delayed it because they were concerned about receiving these out-of-pocket expenses. Is that what's happening for anybody? Yeah, and in New Jersey, we have a lot of supplemental insurance plans, but at the same time, it still isn't covering everything. And then Deontay, you're saying incarceration. So if somebody is incarcerated, then that is going to create a barrier for healthcare, right? We don't focus as much on that topic right in this presentation, but if that's something that you're interested in learning more about in terms of how incarceration potentially impacts social determinants of health, we can definitely look into that. Yes, and also accessing behavioral health, right, Shannon? So really thinking about providers, right? If you look at somebody who is like in private practice, counselors, social workers in New Jersey, as a licensed professional counselor, I can't accept Medicaid. Right, there's a complete lack of access. And it's incredibly challenging, right? Because, and now we're getting into this shortage of providers, right? So I want to jump ahead here, right? So lack of providers due to the area and or office availability, and then this lack of diverse providers. So in terms of the lack of availability and access to providers, right, that's going to create this lack of access to care. If providers aren't able to serve in an area, you are now creating this idea of a medical desert, which we're going to get into in a little bit. Additionally, office availability, right? So if you have somebody who is maybe trying to work, or you have somebody who is employed at a full-time or a part-time basis, and a doctor's office doesn't have any appointments after 5 o'clock, that's going to create a lack of access. If you have somebody who can really go on the weekend, that's going to potentially create a lack of access. And then this idea of the lack of diverse providers, right? So in New Jersey, we have a lot of individuals who speak Spanish. We have a lot of individuals who speak Punjabi. That's the language. Is that the language, Dawn? Or are you, Dawn? Are you there, Dawn?
I'm right here. Yes, Punjabi.
Punjabi. Thank you, Dawn. So if we don't have providers in our state that speak those languages, that's going to create a huge barrier for individuals to go to the doctor, right? Because if they are not comfortable speaking English and they can only speak their first language, they're not going to be able to go to the doctor. What about, yeah, Dawn?
I'm sorry, I just wanted to interject on that topic of language. One of my neighbors actually she knows what I do for a living, and she was saying that she would like to get into therapy for depressive symptoms and anxiety. And I was trying to assist her, but she primarily speaks Punjabi. The closest provider was in New Brunswick, which you know the area. But
Very
that's
far from you.
40 miles.
Yeah.
So and they had limited, I want to say luckily because of COVID, they had telemedicine available, but it's not going to last, right? So she's going to have her therapy interrupted and may not be able to find another provider.
Right. I just want to sit with that for a second, right? Because thinking about that. So the closest provider is 40 miles away.
And she's a single mom with 2 children. Yeah.
Right. And now we have all these other factors coming into play, right? So she's a single mom, she's working, she's providing for her kids, she has 2 children, right? She's going to need childcare. It's very, very hard. I have a couple of individuals who are trying to juggle therapy sessions through telehealth and watch their kids at the same time. It's very, very challenging, especially if they're younger children, right? That's going to create a huge barrier. What about out in Washington? Do you have individuals that you're working with that English is not necessarily their first language and they would prefer to see a provider who speaks their preferred language and their first language? So I'm getting lots of yeses and absolutely, right? So how far are you able to find providers that speak their language, and how far, like, is there a barrier to access for that?
And I just wanted to interject, Emily, because this topic stresses me out and infuriates me that people can't, that there's so much more than just the language, right? Like the language is how we communicate, but also the culture. And a lot of the things that don't have to be said when you find a provider who is of a similar culture, or at the very least is culturally competent.
And I thank you for bringing that into the conversation, Dawn, because you're right. It is so much more. When you are seeking medical care and health care, you are going to feel more comfortable going to somebody who will understand your experience and understand the events that are now contributing to this experience. I'm seeing a lot of individuals seeking providers in Seattle, which makes sense because that's a very big city, but 60 minutes away, 2 hours away by car. Brittany, you said that you live in a rural area with a very large population of individuals who are Hispanic, and finding providers who speak Spanish isn't an issue, but finding ones within a 45-mile radius with availability is the issue. And yes, there are definitely translator options. And then Monica said it depends on location. Closer to Seattle has more options. There are a lot of rural areas. Steph, you have a lot of providers that are bilingual. Leanne, you have quite a few providers who speak Spanish here due to being a farming community. But you have clients who need specialists, and any kind of specialist, even English speaking, is at least an hour and a half away by car. And then is it Shavana? I hope I said that right. But you said there's a growing Ukrainian population in your rural community that has had difficulty accessing mental health services without having to travel to Seattle, which is 2.5 hours away. Right. So we're talking about a lot of different cultural factors, a lot of different individuals who are seeking different types of services. We're talking about primary care. We're talking about specialists. We're talking about behavioral health providers. And access to these services seem to be in these larger cities, which are 60 minutes, 2 hours, 2.5 hours away. Right. And that is all going to contribute to a person's decision to whether or not they want to actually go to the doctor, whether or not they want to see that provider, right? And it isn't always a challenge when you think about maybe like a primary care appointment, right? Maybe a primary care appointment that is a well visit, you're getting your yearly blood work done, maybe you can delay that a little bit, right? Maybe you can make time, maybe you can arrange transportation. But when you have an ongoing health issue where you need to see a provider immediately, you're sick, you need to see a specialist immediately, right? Delaying that care could be detrimental to the person's health. And then again, this idea of transportation, right? We're talking about 40, 60, 100 miles away to get to some of these appointments. How many buses would it take if there is a bus system that runs in that rural area, right? How Uber, but how costly is that? And again, all of these factors now are boiling down to these poor health outcomes, which is the person's going to be less likely to seek care, less likely to then receive that preventative care, and then more likely to be hospitalized, right? And this is like a continuum, because you have the person who has now decided, okay, I'm not going to go to the doctor because of all of these issues, right? So now they're not getting that, they're not getting a flu shot. Maybe they're not getting that blood work. They're not attending maybe those well visits in a timely fashion, right? And now something's happening and their health issues are exacerbating, and now they're more likely to be hospitalized. And then, right, we're going back to these, all of these impacts, right? Thank you, Anne, for bringing this up, because now it's impacting employment, right? So if you have to take a half a day to take a full day to attend a medical appointment hours away, that could potentially put your job at risk. And then Brittany, you live closer to Oregon, right? So now your individuals are having to go out of state in order to see providers. And then Brittany, you don't even have Uber, right? Let alone a bus. So people are delaying care, and it is negatively impacting their health outcomes. And we had a whole discussion about how a lot of your individuals that you're working with have experienced reduced access to medical care. So now I want to play a snippet. We're not going to do the whole video because it's about 13 minutes, but I'm going to play a snippet of this video, which talks about some of the health disparities and the COVID-19 pandemic. So African Americans and other minorities contracted COVID-19 at higher rates and experienced greater sickness and higher death rates than other Americans. And these experts are going to talk about that. Did everybody hear that? Because I don't think I actually shared my sound. So I'm going to share my sound now, and we're going to listen for a couple minutes. Let's try this again. Give me a second.
I know when I uploaded it, it asked me to allow that active link. I don't know if it asked you also.
It did. Let me
If you
try
need
it.
to upload, let me know.
Let me try this. Let's see if it'll work this way.
Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. As COVID-19 continues to take hundreds of lives each day in the United States, public health officials say minorities are being affected disproportionately. Early data shows that African Americans and other US ethnic minorities are contracted COVID-19 at a higher rate and experiencing greater sickness and a higher death rate than other Americans. With us to discuss this important topic is Mayo Clinic infectious disease expert Dr. Irene Sear and community internal medicine physician Dr. Wieland. Welcome both of you to the program. So Dr. Sear, we just talked about how COVID-19 is disproportionately affecting different ethnic minorities. Can you explain why these populations are vulnerable to this?
Well, these populations are vulnerable to COVID-19 for a variety of reasons. And some of the reasons include that they have the social economic disadvantage, they have low health literacy, they have immigration status that makes them maybe not accessible to or eligible for some of the resources that we have. They have limited English proficiency those are some of the reasons why they're more vulnerable to COVID-19.
And Dr. Whelan, in your practice, how have you seen this manifesting?
What we see from the data kind of nationally is that you can look at this kind of from a biomedical lens, but also from a social determinants lens, which is kind of how we see things play out across the board with a variety of health disparities. So from a biomedical aspect, the higher infection rates and deaths in these populations are related to existing health inequities. So namely, we know that people with chronic diseases that lead to worse COVID outcomes, like diabetes, obesity, and hypertension, are disproportionately impacting racial and ethnic minority populations, for example, and this predates the COVID epidemic, of course. And then also disproportionate barriers to healthcare access and utilization. But then if we widen the lens a bit more, there are additional observations that may increase susceptibility. So for example, when you look at housing and living conditions, communities with higher racial and ethnic minority populations have higher housing density and more housing insecurity, which makes the social distancing piece harder. And there is less access to healthy foods, which make chronic disease management more difficult, particularly in these times. Racial ethnic minorities are less likely to have the privilege of working from home. They're less likely to have paid sick leave. They're more likely to be essential workers during the pandemic, and they're more likely to use public transportation or to carpool. So kind of in total, both the disproportionate biomedical risk factors and their social determinants lead back to many kind of root causes, including things like, structural racism. The legacy of redlining and housing segregation comes to mind. There's just one example of ways in which these inequities were put in place by design. And so it's up to us to take them out of place also by design. So in that way, the COVID crisis may provide an opportunity to collectively act on these root causes of fundamental inequities that have really been frequently demonstrated here by the pandemic.
So when we look at what's happening within the United States, have you seen particular geographic areas within the country more affected than others?
The data from the United States are difficult to put together in definitive ways. So it's hard to say definitively in terms of age-adjusted models, but the signal is very clear that no matter where you look, in particular, Blacks, Latinos, and Native Americans are contracting and dying from the disease at a disproportionate rate.
So what are we doing to try and address that?
Well, that's a good question. I think in the short term, we can do everything we can in terms of risk communication with vulnerable populations to make sure that the message is there, that their voices are being lifted up so that we can respond in responsible ways as a healthcare community and as a health community more broadly.
So Dr. Sia,
So I could keep watching this video for the next 13 minutes, but unfortunately we do not have 13 minutes to watch this video. But I do want to hear from you, specifically going back to the vulnerabilities that the one doctor was talking about. I think a lot of what we heard was actually information that we've been talking about throughout this webinar. But what are some of your thoughts on this? He specifically also mentioned seeing these impacts on Native American individuals. I know that there are, before the pandemic, I actually went out to Washington State to do a training in person. And something that was shared with me from the participants in the training in FCS was that a lot of the individuals they worked with were individuals were indigenous individuals, which was not something that necessarily clicked in my head living in New Jersey, where I don't know a lot of indigenous individuals who live in New Jersey. So it wasn't necessarily something that I was aware of. So we're talking about these groups of individuals, African American individuals, Hispanic individuals, and indigenous individuals who were adversely affected by the COVID-19 pandemic for a lot of the reasons that we've been talking about. What is everybody's thoughts out there? Was there any new information you heard from this video? Or is this information that everybody was familiar with?
Emily, I just wanted to say one of the things that I noticed happening, or at least being talked about here in New Jersey, and I guess nationally. And if I didn't hear them speak to this, and they did, I apologize. But like, what's happening now as some of the additional COVID monies are running out, right? So some of the services that were put in place to kind of meet and bridge some of these gaps, that helped our folks increase their access to certain resources, whether they be medical care through telemedicine and so on. I think that there's a fear that some of this drying up of resources may also exacerbate some of the experiences that individuals had even pre-pandemic.
You know, Dawn, I don't think that that was mentioned in the video, but I'm happy that you're bringing that point up because and someone out in Washington, you let me know, is Washington still in a state of emergency? Because in New Jersey, our state of emergency has ended or will end. So a lot of the funding, a lot of the telehealth rule for behavioral health providers, community behavioral health providers in New Jersey, for them to be able to provide telehealth services, that is going to be rolled back as of May, which is causing a lot of concern for our supportive housing program here in New Jersey. So I think you're 100% right, Dawn. I think it's incredibly concerning because what he did mention in the video was a lot of the issues with people gaining access that was prevalent before the pandemic. So if funding, if extra resources then allowed people to have increased access, and now those resources are going away, then access is going to go back to the way it was. And as he said, a lot of people didn't have access to healthcare. Leanne, you said you actually work in healthcare and you have many friends who stayed in the hospital setting as COVID hit. There was a massive increase in ER visits because people knew they would not be turned away for being unable to pay. However, they were unaware that unpaid bills would end up being turned into collections. And there was a huge increase in people needing assistance filling out the applications for bill reduction. Oh my goodness. Monica, you said, I think it's just the PHE. I'm not sure what the PHE is. The public health emergency. So Monica, you said you're left with what can we do or what is being done? I'm sorry, that's Shannon. Public health emergency is ending and CARES funds are being rolled back. Okay, so your state of emergency ended back in November. But your public health emergency is ending in phases. Many Medicaid enrollees lose coverage in the next few months. Oh my goodness. So you have individuals that were actually able to apply for and access Medicaid, and now their Medicaid coverage is going to end. Oh my gosh. Oh my gosh, that is a huge, that is, oh my goodness. Yeah, I'm in shock right now. And then Kyle, you said that most of the COVID relating housing assistance will be ending in June and September, right? So now we're bringing, again, this other factor into the mix of, if somebody is now somebody's housing is going to also potentially be impacted, right? So their health insurance is now potentially being impacted because they're going to be losing Medicaid coverage. And then in addition to that, any COVID relating housing assistance that individuals had, they're going to potentially lose as well. Right. So Monica, that also happened in New Jersey, but I don't think that it's from the information I'm getting from our supportive housing providers in New Jersey, there are not a lot of individuals in supportive housing that are necessarily going to be impacted by those redeterminations now going on again. But it sounds like it's definitely going to be a challenge for Washington State. My goodness. So now we're getting into this idea of healthcare and medical deserts, right? So similar to food deserts, healthcare deserts are these areas in the US where people lack adequate access to healthcare services. And there are 6 healthcare services that I want to outline, which are pharmacies, primary care providers, hospitals, hospital beds, trauma centers, and low-cost health centers, okay? When you look at the US, 80% of counties across the US don't have access to services needed to maintain good health. So more than 33% of the US population lives in a county where there's less than adequate access to pharmacies, primary care providers, hospitals, trauma centers, or low-cost health centers. And then, as we know, access is also affected by socioeconomic factors, right? So can the person afford to utilize these services? Do they have internet access to either find these services or to be able to use these services? And does the person have health literacy? Does the person have the ability to understand any materials or education that the provider is giving them? Over 40% of counties in the US also have pharmacy deserts, meaning that people need to drive more than 15 minutes to reach a pharmacy nearby. So in your experiences where you're located in Washington, are you experiencing healthcare deserts or pharmacy deserts? Do the individuals you're working with have access to primary care providers, a hospital, pharmacies? What is your access to these resources? So, Steph, you said there's a huge desert in Island County. Monica, you said 100% have them here. So I want to share this with you. So this is from Rural Health Info Hub. And this is looking specifically at primary care by county. And I'm going to stop sharing this for a second because I'm in presenter view and I want to get out of presenter view. Because I want to see this on my screen. So this is obviously Washington State. And these are all the counties in Washington State. So these counties in this darker blue area, the whole county is a shortage area for primary care providers. Okay. These middle blue colored counties, part of the county is in a shortage area. So I wanna hear from people. Where are the counties where you all are living in? My mouse is over this area right here. Who are in these counties in this area right here? Where my mouse is. Okay, so Christina, you're in Whatcom, which is this top dark blue over here. So your whole county is in a shortage of primary care providers. Where is Spokane? Must be like right here. Is this where Spokane is? Okay. And I only know that because I've been to Spokane. So we're talking about Whatcom and Skagit are these top left corners. People discharging inpatient treatment aren't able to secure mental health or PCP appointments for months. Oh my goodness. You guys named so many counties. So Yakima, Thurston, Jefferson, Mason. Natalie, you said there are a lot of people experiencing long wait times to see providers, especially for behavioral health. Kitsap, Madison, you said the whole county is a shortage area. Benton and Franklin County, that's in Southeast. So I'm assuming that's down here, Kyle. And then Kitsap is directly west of Seattle. And you don't see a lot of issues with finding PCPs, Monica. Elizabetta, is that Klickitat County? Did I say that correctly? Clark County, you're right next to that area, the Sandwich Mid-Blue in the center. Spokane is the middle right. Okay. Jessica, you work in a unique setting where you have 2 primary care clinics in a permanent supportive housing community for the last 3 years. So they have access to pretty robust primary care services twice a week if they want to come downstairs. But I realize that this is not a typical service in the permanent supportive housing setting in Snohomish. But you know what? There is, I think, increased funding in certain states, like in New Jersey. Our healthcare system, so some of our hospitals are actually partnering with housing providers and supportive housing to be able to have that integrated healthcare and housing for individuals. So one of the hospitals that Rutgers is affiliated, University Hospital in Newark, they are affiliated with a housing, they're affiliated with our housing authority here in New Jersey, as well as a funding source to develop apartment units. And some of those units are directly set aside for individuals who were experiencing homelessness. And the hospitals has the ability to refer them to these supportive housing units. And then a behavioral health provider in supportive housing in New Jersey will provide services to them, and they'll have access to that health care. So I'm happy to hear that it sounds like something similar is happening where you are, Jessica. And hopefully more states catch on with this type of integrated care, because it's very much needed and would very much be helpful. Oh my gosh, Kyle, you said scheduling for mental health providers around 6 to 8 months. Deborah, to access specialists, people must travel to Spokane, which is 2 hours away. I hope it's Sagong. I hope I said that right. So the Department of Health and Human Services announced that the public health emergency will end May 11th, 2023. Medicaid redeterminations for Apple Health clients will begin April 1st. It's estimating that roughly 300,000 clients may no longer qualify for Apple Health, but may be eligible for other insurance coverage. Clients will receive a renewal notice prior to the end of the renewal period over the next 12 months. Wow. Behavioral health. I'm seeing a lot of behavioral health. Definitely a shortage of mental health providers. Jessica said having on-site primary care services is an enormous resource for these folks. But it would be great if mental health was lumped in there, absolutely. There's a social work hiring crisis. We're definitely experiencing that out here in New Jersey. So interesting you're bringing up dentists, Heather, right? So that was something I also wanted to bring up in terms of dentists as well as eye care. And the lack of access to those types of providers as well, or the lack of insurance. Because I know a lot of insurance plans won't necessarily cover dental or cover eye exams. And that could be Medicaid, it could be Medicare, or it could even just be your private health insurance. So thank you for bringing that up, Heather. So we have a couple minutes left. But before we go, I did have some other questions. So I think we kind of talked about this. So what are consumer challenges to accessing quality medical services? So I want to kind of summarize what we've talked about. So first and foremost, transportation is very much a huge issue because of the providers being outside of what is a reasonable area, right? So we're talking about hours away in some cases. Oh my goodness, Betty. Your certified counselor, special designation, Washington, mental health cannot diagnose. License is going from 305 to 800. Oh, Ben, thank you for putting this in the chat box. A 4-day free medical and dental care in Seattle from April 27th to April 30th. Thank you for putting that in there. Anybody who's close to Seattle, if you can take advantage of that, that'll be helpful. So we know that transportation is a challenge. Access to providers is a challenge. Transportation is something that's kind of enveloping in there. And then, what else did we say? I think transportation, the lack of providers, behavioral health providers in the area, primary providers, dentists, eye doctors. And then I'll just put this last question out there before we wrap up, right? So why do you think it's hard to access quality medical services? And what do you think could change or needs to change in your area or either in the state of Washington? What are your guys' thoughts? Oh, that's a great point, Dawn. So if you know when your area is doing their homeless point in time counts for HUD, sometimes there are health fairs or free healthcare services offered during those times. So Monica, you said something that could potentially, oh, I'm sorry, Shannon, you said that something that could potentially help is incentives for doctors to go to rural areas, right? I think that's it's a great idea. I'm not sure if it's something that could be implemented in Washington, but I could see how that would make sense, right? If there were more incentives for providers to set up locations in more rural areas, that would bring that access to those areas. So Ben, you said peer counselors will soon be peer specialists. Oh, John, that's a really great idea, right? So people should receive a higher reimbursement rate for travel to rural areas.
Yeah, I think that's the only way to incentivize doctors.
Right,
Right?
right. Give them more money.
They have to do business too.
Right, absolutely. Yeah, and to echo that, Brittany said pay is a huge issue, right? We're seeing providers leave our rural area for higher pay in other counties. Nicole, increased funding for providers to accept Medicaid. The rates have not increased in forever. And care coordination in the clinics. So you guys brought some great points. So we have a couple minutes left. We're going to wrap things up. I do want to be respectful of everybody's time. And then, Betty, I think that's a really great place to end it, right? Better working conditions. So better pay, better working conditions. I think that's what all of us would like in the world, which should not be too hard to ask for, right? But we really just want to say thank you. Thank you guys so much for being so engaging with us today and for participating in the webinar. I know sometimes webinars can be hard because all we can kind of do is communicate through the chat, but you guys really participated today and we very much appreciate that. So thank you for your time, attention, and participation. I do just want to reiterate that today's webinar was hosted by DBHR through the Washington Healthcare Authority. We do want to remind you that the slides, link to the recording of the session and other resources are going to be available in the follow-up email. And also don't forget to check out the Foundational Community Supports newsletter for all things FCS and any upcoming training events. You guys have a great website for FCS. I've been on it. It's fantastic. There is so much really good information on there. So please, if you have not been on there, go ahead. And if you would like more information on becoming an FCS provider, just please reach out to AmeriGroup. They'll give you the information. Ben put his information in the chat box. If you guys would like to share information with each other, please feel free to do so. It's always good to have contact information and to be able to network with other behavioral health and FCS providers in the state. So yeah, thank you guys so much. I'm gonna stop the recording and we hope you all have a great rest of your day.